Welcome to Module 7. Participants and reviewers of the first 6 modules had questions about the standards and about the instruction. In this module, we've recruited some members of the PCORI Methodology Committee and someone from PCORI with methodologic expertise to respond to these questions. Also, we provide a preview of the revised methodology standards that were released earlier in 2016 and were open for public comment until the middle of April 2016. The objectives of this module are to learn more about the standards for disseminating research results and learn more about the standards for registries and data networks. The question that came up most with respect to registries and data networks is what is the difference? And finally, as I mentioned, we would identify important updates to the standards for 2016. Our first speaker is Brian Mittman, who will be addressing standard PC4, Support, Dissemination, and Implementation of Study Results. The standard reads, for study results that are appropriate for dissemination and implementation, involve patients and relevant stakeholders, A, in planning for dissemination from the start of the research study, B, in creating a dissemination plan for the study indicating clinical implications, C, in working with patients or organizations to report results in a manner understandable to and usable by each target audience, and D, in identifying successful strategies for adoption and distribution of study findings to targeted patient and clinical audiences.
Brian Mittman is a member of the Methodology Committee and an expert in implementation research. Dr. Mittman received a bachelor's degree in engineering from Princeton University, a master's in sociology from Stanford, and then a PhD in organizational behavior and management from Stanford Graduate School of Business. Dr. Mittman, could you give us a sort of a better introduction or more information about what you're doing now?
Sure, and thank you for the opportunity to contribute to this model and to offer some thoughts and comments on this particular standard. In addition to my role on the PCORI Methodology Committee, I also serve on one of the board subcommittees that oversees and guides the dissemination and implementation work of PCORI, so I have a keen interest in this standard in particular. My current professional affiliations include a research position at the Department of Veterans Affairs, as well as a position at Kaiser Permanente, Southern California, in the Department of Research and Evaluation, and some time allocated to the CTSI at UCLA.
And just so the folks know, you've been on the Methodology Committee since it was created, is that right?
Yes, since the inception, and have tended to focus my efforts on areas related to dissemination and implementation, and ultimately the impact, the societal impact and benefits of the work that PCORI is supporting.
So to the standard on dissemination and implementation, this standard applies to investigators, to researchers, and essentially it says that researchers should support dissemination and implementation of study results. And with the questions we got about it were if we could clarify the role of the researcher in dissemination efforts. Suppose an investigator completes a study and is ready to publish it. Is that the person who's primarily responsible for disseminating the research?
So there are actually two aspects to the question and the feedback that we received. And as you recall, this was the focus of a fair amount of deliberation within the Methodology Committee at the time that we were wording the standards. And there are two key arguments that and ideas that underlie and we hope are implicit in captured in the standard. One is the question of what should be disseminated and what level of effort should be invested in dissemination and implementation, who are the appropriate target audiences. And unlike what we often see on the part of research funding agencies and researchers, which is essentially a one-size-fits-all approach, where all investigators who are asked to include a dissemination plan in their grant application will list the professional meetings that they will attend, the journal articles that they wish to write, and the number of policy and practice leaders they will reach out to in order to try to encourage adoption and use of their findings. The Methodology Committee, as well as the broader PCORI staff and our partners at ARC who are involved in dissemination, we all recognize that dissemination plans need to be individualized. that many individual studies represent only a portion of a collective evidence base or an evidence base that will eventually be combined with expert opinion and incorporated into a clinical practice guideline. But the key idea is that the strength of evidence, the level of both internal and external validity, and the level of effectiveness versus efficacy evidence involved in a study. All of these are important factors that determine who the appropriate target audience should be, and to what extent is it appropriate to expect policy and practice leaders to pay close attention to the finding and begin to change their practices. And this, of course, applies to individual clinicians as well. So the first key point that we tried to convey through the standard is the idea that we need to assess the level of evidence, the strength and size of the study, and how the study finding relates to a broader body of evidence that may exist or may need to be developed before we decide if this finding is, in quotes, definitive, whether it does warrant practice and policy change, or whether the primary target audience should be other researchers who would then replicate the study or add to the evidence base, or evidence-based practice groups such as Cochrane Collaboration and the ARC EPCs that are charged with evidence synthesis. They may, in some cases, be the primary audience. Of course, all studies should be disseminated, or their findings should be made available to all target groups, but the implications of those studies may differ. And again, oftentimes an individual study does not offer strong enough, broad enough evidence to justify practice change quite yet. The second half of the question has to do with essentially roles and responsibilities for dissemination and implementation. And again, in the standard, we tried to capture the idea that effective dissemination and implementation are, in a sense, a team sport. They require a number of different stakeholder groups who coordinate and collaborate to disseminate and implement to achieve practice change when practice change is appropriate or policy change. And that oftentimes researchers are not best positioned to try to advocate for practice change, but instead are best placed to help interpret the finding, to comment on its significance and importance relative to the larger body of evidence, to help identify the target audiences and the groups whose policies and practices may need to change, and to essentially help support and guide other stakeholders, such as ARC, such as PCORI, as well as specialty societies and other stakeholders, all of whom may actually be involved in active implementation efforts. So the key message that we tried to convey through the standard is to have the researchers help develop a dissemination and implementation plan by examining each of these considerations, and to support and facilitate dissemination and implementation, but not necessarily, and in fact in most cases probably not, be actively involved themselves in very intensive and costly dissemination and implementation efforts.
Let me ask you, since you're focusing on the role, I think, of individual studies, results, and the broader context of evidence, but also in the broader context of translation and of, I think, PCORI's goal, really, of accelerating translation of research. So one element of that, I think, by your mention of systematic reviews, is to get the new studies into systematic reviews and update those and say how much the gaps in the evidence have been addressed. Do I have that right?
Yeah, I think that's accurate to the basic idea that the researchers know best how their findings and their questions relate to the larger body of evidence, and that they have a responsibility to facilitate the systematic review team's use of their work by ensuring that it is presented with the appropriate caveats and background and explanations and implications.
So it seems to me that in order even to do their role in the bigger picture of a multi-component approach to implementation, that the investigators, the researchers, need to know something, I think, about implementation science, about the work that you do and so on. I know you've written about the barriers to dissemination and implementation, like professional norms, uncertainty, multi-level influence, and so on. What would you say would be an approach for an investigator to learn, let's say, a enough about implementation science to be helpful to the people who are experts in those areas.
I think it's a good point, and it is true that for any individual investigator or a PCORI-funded team or a team conducting research funded by any agency, for them to successfully play their designated ideal role in the kinds of partnerships that we've been discussing to facilitate appropriate and effective dissemination implementation. They do have to have a basic understanding of some of the key barriers and of the processes, the kinds of decisions that need to be made, the ways in which a dissemination and implementation plan eventually will be designed and then carried out. I suppose there's the implementation scientist part of me who is interested in advocating for greater investment in our field, who would argue that we need more implementation researchers and more expertise. I think at minimum, what you're suggesting is that we do need more basic awareness of some of these key factors, and perhaps this is a responsibility of those of us in the field to convey enough of the key principles and ideas in a format that would be accessible to those who work at earlier phases of the pipeline than we do, those who are conducting the patient-centered outcomes research, the comparative effectiveness studies, developing guidelines, that we need to provide an accessible summary of some of those key principles. I think the state of the field is such that there is a fair amount of implementation science expertise scattered around the country. I always encourage colleagues in my local institutions who are applying for PCORI funding and funding from VA and NIH to reach out to one of their colleagues for a brief consultation on some of the dissemination plan requirements for their grant applications, to make sure that they do gain that basic knowledge and have the general lay of the land, in a sense, so that they are able to speak appropriately to the activities that they will plan and they will conduct. But this also points out perhaps an opportunity for both ARC and PCORI in terms of our broader obligations to, as you indicated, accelerate impact and appropriate adoption of research findings, that we may have a role to play in providing that accessible summary of principles and guidance that I mentioned. But in the meantime, again, I think the obligation on the research teams is to seek out local expertise in consultation, and these are not complicated issues. I think, as with other forms of consultation, from a biostatistician, from health information technology expert for certain kinds of studies, relatively brief, efficient conversations and reviews of documents are often enough to obtain the kind of guidance that a PCORI-funded investigator would need to understand how to write the plan and how to respond appropriately to this particular standard in the methodology report.
I would encourage listeners to go back to the methodology report and read what it says about the patient-centeredness standards, and in particular about this one. Thanks very much, Dr. Mittman, and it's good to talk with you.
Thank you very much.
We now turn to questions about the standards for data registries and data networks. The text of these standards is too long to fit on a slide, so I've given you the outline. For the standards for data registries, there are 3 standards. DR1, requirements for the design of registries, which includes the purpose and protocol for the registry, plans for data safety and security, data elements and quality, confounding, systematic participant recruitment and enrollment, and participant follow-up. The second standard for data registries concerns documentation and reporting requirements of registry materials, characteristics, and bias. And the third standard is about adapting established registries for use in PCORI research. The standards for data networks as research facilitating structures are also long, and so again I've just given you the outline. The first standard for data network lists the requirements for the design and features of data networks and describes the standards for data integration, risk assessment, identity management, and authentication of individual researchers, intellectual property policies, standardized terminology and coding of data content, metadata annotation of data content, and the common data model. The second data network standard concerns the selection and use of data networks for particular studies.
I'm interviewing Adam Wilcock, a member of the Methodology Committee at PCORI and its expert in informatics, to answer some questions that came up from users of the course. Adam is a professor in the Department of Biomedical Informatics and Medical Education at the University of Washington and the Chief Analytics Officer for the University of Washington Medicine. Prior to that, he was the Director of Medical Informatics at Intermountain Health in Salt Lake City, Utah. Adam is going to comment on the standards for data networks as research facilitating structure. Adam, one of the reviewers raised a question that didn't think it was clear from the standards what the relevant differences and similarities are between networks and registries, which are two sets of standards. Can you help delineate the differences and similarities between data networks and registries?
Yes, I can, and thanks, Mark, for bringing up this question. I admit I found it a little confusing, too, because I think there's overlap in terms of when someone's using the data from either data networks or data registries for research, and it can be easy to see them as the same thing. But there are some important differences. Data registries are generally proactive in their data gathering. That doesn't mean that they're proactive in the way that data are gathered for a prospective trial, but they're proactive in when a patient meets certain criteria, they're entered into a registry. And that allows the research coordinators or whoever's collecting the information to have a little more flexibility about the information that's collected. Usually the data that are needed for a registry are defined in advance of the data being collected for them, but it still often requires some review of electronic health records and some abstraction of that information as the data are loaded into a registry. Registries are also, like data networks, often collecting data across multiple institutions. And so there's some considerations that are going to be similar between data networks. Now, data networks, usually it's where you have multiple organizations and they all have data probably from electronic health records, maybe from other sources, and they're trying to merge these data together so that you can have a larger group of data in order to perform observational studies. Data networks, they're already collected as part of some other activity, and we just want to use it for what I would call opportunistic observational studies. Now, because of that, when you look at the standards that we have for data registries, a lot of the standards are dealing with how we're ensuring that we're collecting the data on an individual level. So standards about patient follow-up, standards about data quality assurance and consistent data collection are really relevant to data registries. In data networks, there's data information about, or there's standards relating to data integration because that's more important. You're integrating data across different sites. Now, interestingly, data networks, there's kind of two types of data networks and that people generally use. And the nuances between them, in terms of observational, it relates to the observational studies that would be done. Sometimes a data network would be collected across multiple organizations that really aren't expected to have the same patients across these networks. And in that case, you're really just trying to see with a more generalizable sample or a larger sample that you can use for observational studies. So imagine a study that used data from different non-contiguous states where you're not expecting the patients to be the same patients in one that would be in one health system as the other. Sometimes you also might be using data networks in order to have a better longitudinal view of patients. So if you're creating a local data network where you're using data from outpatient clinics as well as data from home care or long-term care facilities, you would be creating a data network where you would be expecting the individuals to be the same across these different organizations, or at least some individuals to have data within each source. And the reason for creating that network is that you have a longitudinal view of those individuals.
So, for example, if we took the standard regarding the common data model, a common data model wouldn't be needed in a registry retrospectively. In other words, people would agree on what data they're collecting. But in a network, everybody's collected data in their own ways, and there needs to be some kind of way of reconciling that. Is that a meaningful difference?
That's a really good explanation of that. for example, the standards about systematic patient enrollment and follow-up and consistent data collection, because those are with the registry, you've kind of already solved for a common data model. But where the data are already being collected, you've got to make abstractions from just the data, not from reviewing the individual patients, just from the data as it is, into a common data model that then can be used across the different organizations. And I appreciate you bringing that one up specifically because it really highlights the differences. It's a standard that highlights the differences between them. Whereas some other standards like data safety and security, those are similar across both of them because in each case, whether it's a registry or a network, you have a lot of data that could be identified where you're going to have identifiable indicators or identifiable fields, and you need to be careful about this safety and security. So there are other standards that do cross better.
Great. So let me ask you something else. I think some people will be unfamiliar with the idea of a data network as infrastructure for comparative effectiveness research. I think maybe if you could give us an example of a data network as the infrastructure for comparative effectiveness research, that might help some people understand what the data network's role is.
Sure. And I'll give two examples. Before I talked a bit about where you might have two different types of data networks. One would be local, where you're expecting the data network to provide more a longitudinal view of the patients that would be, or the subjects that would be in a network, and another one would be where it's across multiple organizations. So as an example of a local network that had the benefit of longitudinality, I'll give the example of the Washington Heights Inwood Informatics Infrastructure for Comparative Effectiveness Research, or WISER, which I was the PI of that project, and now Sue Bakken is leading it at Columbia University. This was a network that we created in Washington Heights, which is a part of northern Manhattan, where we had patients that were seeing multiple healthcare facilities in that area. They were being seen in inpatient settings, they were being seen in ambulatory settings, some were in long-term care and some were in home care. And the purpose of creating that network was so that we could link patients across these different sites and get a more comprehensive and longitudinal view of the care that these patients were receiving, and that was necessary in order to perform some comparative effectiveness studies. Another type of network are the PCORI networks that PCORI has been funding, and these typically are across organizations that they may be geographically located, so you may have a PCORI network that's localized to the northeast part of the country or to the southwest part of the country. But in each of those cases, you're still not expecting the majority of the individuals to be crossing the different organizations that you're linking. You're really linking organizations using a common data model just to be able to do queries across those organizations in order to find enough patients in a pool of organizations rather than a single organization where you can do prospective clinical trials, or so that you can build up a large enough number of patients that you could have a greater power in looking at different questions that would be answered by an observational study.
It's interesting when you mention enough patients. Actually, there was a question about whether the slide that I gave on why we should have data networks or why we need them didn't mention rare diseases, and somebody asked if that should be, if that is indeed a reason to be having data networks.
I think rare diseases are a really good example of why you would want data networks, though I would give some caution in using data networks for rare diseases just for doing observational studies. I think the example of using a data network to find out where the different individuals who have a rare disease may be located and trying to figure out the ways to reach those patients and then building up a prospective trial is a good example. And I think cancer has done that really well with a lot of studies that they've done where they've found the number of patients that have different cancer and kind of distributed the prospective trials and the prospective data collection across a bunch of different institutions because they didn't have enough individuals that met the criteria because the criteria made it a rare case. So I would recommend not using data networks for rare diseases just for doing observational studies, because in general, rare diseases, there's a lot of data that wouldn't be mapped directly to a common data model. So the data that may be going into a common data model across these data networks would be lossy on these rare diseases. And it takes a lot of time kind of digging into the data, figuring out how the data on rare diseases are really captured. Data networks are generally expected to be a network across, that can be used for not just one disease, but multiple diseases, and are a good starting point. When the diseases get rare, the chance of losing information that would be really important for studying that rare disease, losing that information that doesn't get translated from the clinical information systems, even if it's in structured form, into the common data model, makes it difficult.
So it would seem that for the investigators, clinicians taking this course, they might look to the data registries in the data network section and then maybe look at PCORI's website to learn about PCORNet. If somebody were investigating a rare disease, they might think about a registry, or they might think about the data networks at least to identify people and places that might be brought together for a prospective study.
Yeah, and I think that if they want to look at different initiatives that have tried to do that, especially for rare diseases, the CA-BIG initiative that was funded by the National Cancer Institute, even though that has not been pursued based on some difficulties in implementing that, I think the vision that was seen in CA-BIG in trying to use data networks for rare diseases is probably a good idea. We don't have a lot of really good examples outside of cancer of these data networks for rare diseases. Hopefully, the creation of more data networks for general purposes will lead to discovery of networks that could be created on an ad hoc basis for specific rare diseases. And at that point, I'd recommend people kind of looking not as an overall infrastructure, but in some of the lessons learned in CA-BIG.
Thank you very much. I think students taking this module will be able to see something about the particular network, the CA-BIG and PCORNet, on the screen. We're going to stop there. Thanks again for being with us here.
Thank you so much for inviting me.
This segment of this module is about the revised and new standards. You've heard us refer before to the fact that the original standards that were approved by the PCORI Board of Governors underwent a revision over the last year. That revision was led by David Hickam, who is the Director of Research Methods at PCORI, and Dr. Hickam is here to discuss the changes in the standards and the new standards that have been added to the previous one. Dave, thanks for coming to the course. Can you say a word about what you do at PCORI?
So thank you, Mark. I'm happy to be here to talk about our work at PCORI around improvement of methods for comparative effectiveness research. So I'm a program director of PCORI. I got involved with PCORI right when we started to provide funding for individual research projects. So I was involved with how to provide a sense of direction for the funding programs, and really to understand how we could find the best comparative effectiveness research projects that would make significant contributions to the evidence base in clinical medicine. And as everyone knows, an early part of the work at PCORI was to develop a set of methodology standards that essentially provide baseline guidance for how to use best methods in the conduct of comparative effectiveness projects. And we had the opportunity to work with the methodology standards and really evaluate individual projects and how they kind of lined up with the methodology standards over about 2 years, between 2012 and 2014. And we found that we gained some insights into how well the standards work, whether there were any kind of areas where there seemed to be gaps in the standards, or how we might just make the standards more understandable for use by researchers. And so we were able to begin a process about a year ago in which we carefully went through each group of the 11 original groups of standards and think about what we've learned from our cumulative experience. Also, what was new in the field? What new insight about the use of methods had come along during that period of time? And so that led us to use a pretty straightforward process of doing some rewording of the standards, and some, in rare cases, we actually dropped one or two of the standards. We decided sometimes to reorganize or reorder the standards within a category, and sometimes combined standards. So we would have a more parsimonious set of methodology standards. Parallel to this activity is we developed one new group of standards, which I think we're going to talk about a little bit later, but those are the new methodology standards on research designs using clusters.
That's great. So I'm going to tell the audience that as of the date that we are talking now, in early April, the revised standards are up for public comment on the PCORI website. David, can you tell us when that public comment ends? Is that
Yes.
a date already set?
Yes, as a matter of fact, the public comment period is going to close at 5 p.m. on April 11th, 2016. So I think what that means that anyone who hears this discussion between Mark and I will be hearing it after the public comment period has closed.
And do we know when they might be officially adopted?
We plan to get this work finished by the summer of 2016. We do need to go through the whole group of public comments that we've received, determine what changes in the draft set of new standards would be appropriate based upon the input from the public, and then finalize the new standard for essentially endorsement by the PCORI Board of Governors. The PCORI Methodology Committee will be involved in this process so that they essentially are the experts who make the decisions about what the standards will consist of. But that, we're talking right now in April, so we expect that process of finalizing the standards will get resolved by about the end of May, and then that will allow us to move it forward from there to the final release by PCORI in the summer of 2000.
What I thought we'd do next is highlight a few of the changes. Most of the changes in the standards make them clearer and shorter, but in a couple cases there's new material or something that wasn't included in the teaching or the discussions we've had in the previous modules. And the first one that I wanted to ask you about was the standards associated with patient-centeredness. Now, in that group of standards, one of the main differences is that the standards now refer to the engagement rubric, which is also posted on the PCORI website. Can you tell us why we added a reference to the engagement rubric?
The original methodology standards really kind of cut some new ground by really calling out the importance of partnerships between researchers and stakeholders in actually conceiving and planning and carrying out research projects. And those stakeholders include patient partners. These would be, patients who participate as members of the research team. And while the standards basically stated that it's important to have an interdisciplinary team, including researchers and stakeholder partners, they didn't really speak directly to how to carry that out. In other words, the standards said it's important to do it. Here is some of the ways in which stakeholders can provide input. But what we found, not surprisingly, was that researchers came back to PCORI and say, we want more information. We really want to understand how PCORI defines a model of researchers and stakeholder partners working together. And so the PCORI Engagement Department got input from a lot of different groups and developed some more specific guidance, really sort of examples of how researchers and stakeholder partners can work together. And those were released by PCORI and were called the engagement rubric. Those have been out and available to people now for about 2 years. We felt like it was important that there be a linkage between what's stated in the standards and the more detailed guidance provided in the engagement rubric. So we specifically made that connection when we revised the standards on patient-centeredness.
I'm going to jump ahead to a different addition to the standards. This is in the Standards for Preventing and Handling Missing Data. When the standards for preventing and handling missing data were written, they referred really to only one kind of missing data, which was when the participant in the research drops out of the study entirely. And now they refer to other forms of missingness. Can you tell us about the other forms of missingness and what the change in the standards really refers to?
I think that this refers to the fact that missing data can take different forms. Probably the easiest one to understand is when a participant in a study, for some reason, loses contact with the research team. And so essentially, there's no more data available for that participant, even though there was a plan to continue to, gather outcome information from the participants for a longer period of time. That's the classic case of dropout. And in fact, the concept of dropout is still referred to in the missing data standards. But obviously, I think everyone understands that there's other ways you can have missing data. You may, for whatever reason, not be able to get input from a participant at a certain planned time point, but that person hasn't dropped out. You're able to actually get information at the next time point. Sometimes participants aren't comfortable answering some of the questions that are asked of them, and so they'll selectively choose not to answer some of the questions. There also may be other types of data that are used for outcomes, and those may come from electronic health records or laboratory data, and for some reason those just aren't obtained, even though the participant continues to be followed in the study and continues to provide future data. In revising these standards, we tried to capture the diverse reasons by which data would be missing in kind of an unpredictable fashion as you follow the participant.
I'm going to jump now to the standards for data registries. The first data registry standard, DR1, used to have an item called patient follow-up, and now that item, which has been revised completely, talks about the registry purpose and protocol. Can you tell us why the registry purpose and protocol is important and why the change was made?
Yeah, and thank you for that question. If I am the designer of a registry, my goal is that it's the highest quality source of data that is possible for, the clinical area in which I'm designing the registry. And so a couple things here is that in order to ultimately, down the line, get a good data set from a registry, you need to make sure that the registry aligns both with its purpose and also how you can carry it out and how you can really get participation, because no registry is going to be successful if the patient participants don't see that it's important. And that, we have to acknowledge that the patients are really the ones who provide a big piece of the work in carrying a registry forward. And so that language that you just described really calls out the importance that the way that you can get to that goal of having high-quality data come out of your registry is to engage patients as partners in the development. It says registries should aim to be user-oriented in design and function. That's kind of driven by, make this so that patients both want to participate and also find that it's workable to participate in providing the data that the registry operators are asking them to provide.
Great. So we're going to move on to the new set of standards that you referred to before, the standards on research designs using clusters. So this is the 12th group of standards. We had only covered 11 to this point because until now there weren't standards for cluster studies. Start by telling us, why are cluster designs important to patient-centered outcomes research?
Patient-centered outcomes research is a type of research in which we examine the outcomes experienced by patients who receive alternative types of clinical interventions. Those clinical interventions sometimes can be very clinical. They can be such things as receiving one medication versus an alternative medication. But as you know, a lot of the types of care that patients receive are more complicated than that. They can be such things as strategies to manage clinical conditions over a period of time. They involve direct interventions by healthcare providers delivered to patients. One version of that would be what's called case management, or where over sort of a continuity period of time, members of the delivery team directly interact with patients to help them improve their functioning. And we found at PCORI, as researchers brought to us ideas for new research, that often these clinical interventions were complex. They consisted of specific types of behaviors of members of the healthcare team that were integral to delivering the intervention. And so, when you think about it, this is really a dyad situation, that there's an involvement not just of patients, as people who carry out the treatment, but also the activities of the members of the healthcare team in carrying out those clinical interventions. The concept of cluster randomized trials, was developed within the last couple of decades, maybe 2 or 3 decades, as a way to account for that complexity of care that's delivered to patients, in which it's more complicated than just saying, let's take every individual patient and randomize that patient to one of the other interventions, because the interventions require the involvement of providers. So we might think about a cluster situation in which a group of patients receive care from a single healthcare team, and that what we're really asking for in the study is for those healthcare teams to deliver one or the other type of clinical intervention. And so that sets up the stage for the scenario in which you would randomize the healthcare team to one or the other of a clinical intervention, but the outcomes of those interventions are measured at the level of the individual patient. And so there is a connection between the patients and the teams that has to be accounted for in the design. And so it was recognized by the PCORI Methodology Committee that it would be very valuable to develop better guidance about how to use these cluster designs in the conduct of research projects. And so we obtained input from a group of experts, people with a lot of experience with both how to design and manage studies with cluster designs, but also how to analyze the data that come out of those studies. And that led to this new group, this draft group of methodology standards on designs using clusters.
Now, the title of these standards is Standards of Research Designs Using Clusters, and I think you've covered some of the issues in the standards, certainly RC1, which is about specifying the objectives and the interventions at the cluster and individual level, and RC2, which has to do with reasons why you might do a cluster randomized trial in the first place. The next 2 standards, RC3 and 4, are more analytical ones, having to do with power, sample size, and the appropriate statistics for analyzing data from this. I'm going to ask you about RC5, which says because cluster randomized trials often involve a limited number of groups or clusters, stratified randomization is recommended. And it goes on to talk about how to randomize when you may only have a limited number of groups or clusters. I guess this is the first of the standards that specifically talks about randomization. And I wondered if you could comment on the value of randomization in this type of study.
So the issue here is that because you're grouping patients within a group that, often is represented by a clinic or a healthcare team, that practically speaking in these studies, the number of clusters is relatively small. It might be as small as 8 or as big as 50, but even if you have 50 clusters, I think you know that in randomized controlled trials that include randomization at the individual patient level, a sample size of 50 would still be considered a very small clinical trial. And so there's a couple of concepts here. One is, why are we even calling out randomization? Is it kind of naive to think that you can randomize a small number of people and really account for the confounding that you're trying to correct for? And the realization that if you've got a lot of variation in the characteristics of the clusters.
All right. And finally, on these cluster randomized trials, I think PCORI has funded some cluster design studies. Can you give us an example of a PCORI-funded cluster study that's either ongoing or completed?
Yeah, we've got a project right now that is almost finished, so we're really looking forward to seeing the results of that study come out later this year. The principal investigator for that study is Daniel Turkin from the Group Health Cooperative in Seattle, Washington, and he was interested in trying to gain a better understanding of how you could organize care for primary care providers to improve outcomes for people with low back pain who come to the primary care clinic with the complaint of low back pain. He, based upon some prior research, had identified essentially a tool, a clinical tool for classifying these low back pain patients by their level of risk, essentially risk of poor outcomes, of lack of improvement in the back pain, and compared with what you might consider a more conventional approach, which is to provide information to the primary care providers about sort of who they can refer the patients, the low back pain patients to get care. So it was a study of a specific clinical tool that can be used by primary care providers. And so in that study, they took the primary care providers who were in a set of clinics in a healthcare system in the Puget Sound area of the state of Washington and randomized each primary care physician to these two alternative strategies for helping the primary care providers to manage patients with low back pain. So I think you can see here, because it's a tool used by the primary care providers, a cluster randomization scheme made a lot of sense. And then they gather the outcomes, basically how well the patients did with their back pain episodes at the individual patient level. So it's kind of a classic cluster design.
I think that's our last question. I want to thank you for helping out with the course today.
It was great talking with you, Mark.